Hi, everyone. I'm David Williams, president of strategy consulting firm Health Business Group and host of the HealthBiz podcast, a weekly show where I interview top healthcare entrepreneurs about their lives and careers. If you like this episode, I hope you'll hit the like button and subscribe. My guest today is Bill Kerr, co-founder and CEO of Avalon Healthcare Solutions. Bill, welcome to the HealthBiz podcast.
Thank you, David. It's a pleasure to be here.
Great. Well, I have heard a lot about your company, and so I'm happy now to hear more about it right from you. Before we get into that, I would love to hear about your background and your upbringing. And I have two main questions. With any childhood influences that have stuck with you through your career, and why do an MD and an MBA?
Thank you for both good questions. So on the first one, I grew up in a small town in North Arkansas, and that's relevant because my dad was a small town physician, Mountain Home, Arkansas. He was the sixth doctor there. And as a result, I spent a lot of time around the healthcare community. There were occasional Saturdays where I'd be parked in the doctor's lounge and he would go round on patients. And so at an early age, high school, I decided I wanted to go into medicine, but I really wanted to go into medicine to help doctors like him deliver better care. That was my real motivation. And I thought the way to do that was through research. So much of my early focus was to become a researcher and physician. So I was able to do a lot of DNA sequencing as an undergrad as part of my honors thesis. Even then during med school, I was able to get a scholarship to go overseas to Oxford and do research using was then a new technology called PCR to try to understand why some cancer cells spread and others don't. And then I went into Baylor residency with the intention of becoming a pediatric oncologist, and through that, continuing my research, and in fact, enrolled in the oncology fellowship. A couple of things happened, which I'm happy to get into if that's useful, but ultimately they led me to say cost quality access was a bigger limiter of outcomes than ignorance of disease. Mm-hmm. And so I like to argue that I didn't switch careers, I switched research topics. Instead of why some cancer cells spread, I'm on why is it so hard to navigate the healthcare system? Why is it so hard to afford it and to kind of afford population outcomes? And I had to then get a business degree because I had never, and the old joke I tell is I had never had a business degree class. I couldn't even spell ROI.
Yeah.
And so the MBA was really to teach me the language that I was moving into.
Very interesting. You know, I've interviewed well over 100 people for this podcast, and there's some themes that develop. And you're not the first one that I've spoken with who parents were, mother or father or both were physicians. You grew up around that, and then it led you in a certain path. There's actually another person that had a similar title to you at one point, the chief medical officer of Kerr. I'm talking about Mike Cantor, who's I believe his father was a doctor, and he became a doctor and a lawyer. So I don't know, he drew maybe slightly different conclusions there, but I think the same basic path of wanting to be in the kind of the helping and healing profession, and knowing that, you know, there's some things that stymie the ability of a well-trained and well-intentioned physician to be able to get everything done they want to do for their patients.
I just had some interesting experiences with patients who in Houston did not have healthcare coverage. As you can imagine, the Texas Medical Center has a lot of undocumented people who may find their way there. And it was the first time I really faced the scenario where we knew what to do for patients, but because there was no funding, it couldn't be delivered. And that was a real eye-opener for me, and is really part of what motivated me to move in this direction. How do we get everybody the best evidence-based care and not let funding be the challenge?
Makes sense. So early on in your career, you would work with some health plans, I believe, and then I already mentioned CareCentrix. But can you talk about what your sort of career progression was once you got a little bit more on the kind of the combined business and medicine side of things?
Sure, absolutely. So my thought was at the time, so this is in the early to mid 90s, kind of what I would call wave one of the HMOs. My thought was to go work with an HMO for a few years, almost like a fellowship. I thought I would do 3 to 5 years, try to understand kind of that upstream piece. I will tell you, David, best seat in the house if you want to understand the challenges of cost quality access is chief medical officer of a health plan. In any given day, You can hear from an employer about how they can't afford the rate increases that are happening for their employees. You can hear from hospital CEOs about the challenges of covering the ER or nursing costs today. You can talk to doctors about the cost of a radiology tech or challenges they're having in malpractice. And through case management, you talk to patients who cannot get an appointment or who navigate systems. So I stayed on that side for almost a dozen years, over a dozen years, because
Yeah.
it was such an interesting place to be. Some of the things I think the listeners will probably know is as ACA came along, there were some things that had already started prior to ACA, but were embedded in ACA, which is the medical loss ratio requirements or the claim requirements. So Medicaid had done that for a
Yeah.
while. Medicare was doing that, must spend 80, 85 cents of every premium dollar on claims expense. That effectively constrains some of the investment that health plans can make. If you know, effectively, it's profit and investment and admin costs that are affected. And so, what was happening was my area of the health plan was actually part of the area in which we were having to reduce investment. And so, the anecdote I share is, quite frankly, we were being asked to reduce our nursing staff and yet still lower medical costs and improve outcomes. And I just found that
Mm-hmm.
increasingly difficult. And yet over here on the other side was all this private equity money looking for a way to generate value. So I very consciously made the decision in '09 to test whether or not one could use private equity money to build services and solutions that would go back into the health plan, kind of into the area I used to run, and deliver the outcomes. And CareCentrix, I was very fortunate to know the people who were helping to spin it out from underneath Gentiva. And they, quite honestly, they had an operational hub about a mile from my office at the time. So knowing the people, knowing the home side of service fascinates me. I think it's going to continue to grow. I chose to give that a test run. And I would tell you that from my perspective, it has worked out very well. There is plenty of money looking for innovation on the private equity side. And you can, in fact, build services and solutions that feather into the health plans and help those people deliver cost, quality, and access enhancements when they can't build those solutions as easily anymore because of some of the constraints I mentioned.
Got it. So very interesting. And then, you went on from there to Avalon. And I wonder, what was the inspiration to be a co-founder of that company? In some ways, I think it's a kind of a logical next step from what you've done from the health plan side and then on to CareCentrix.
Yeah, so, a couple things. I already mentioned that I think the home side of service, which is where CareCentrix operates, is a great value prop. I think all we're going to do is see more and more services delivered in the home. The other strategic piece for me, since I'm so focused on cost, quality, access, is lab testing. It's been said for decades that 70% of all clinical decisions involve a lab test. And that was before we started seeing the explosion in genetic testing, which most people know about. So that's strategically very interesting to me as well. And I had the good fortune of meeting two other people with an interesting lab. So Adam Bowler, other co-founder for us, had been involved in some companies that manage lab billing and had seen some of the waste that's in the system. And then Ezra Perlman, who is the president at Francisco Partners, who heads up their healthcare IT, has always been motivated around things that, as he will tend to say, are on the right side of the healthcare equation. So really promoting outcomes. So Adam knew a little bit about lab and how to build companies around a customer called a ground up. Ezra had capital, and I knew how to build a program that would feather into the health plan operations. And lab, as I already said, strategically interesting because it is the way I think about it, it's the diamond in the decision tree. If you think about workflows, if you don't pick the right pathway because you didn't get the right test or you didn't interpret the result correctly, then everything else you're doing around adherence to therapy and evidence-based medicine is on the wrong pathway. So I find it really compelling. And then on a personal note, PCR, which I was able to use in the very early days for research, is one of this, and DNA sequencing, which I was able to do some in the very early days. Those are all state of the art now. So it's kind of fun for me personally to come full circle from a young man trying to do research to now trying to scale those tests into the healthcare ecosystem.
No, it sounds great. Now, the thing is, you make it sound fairly straightforward, if I may say. And at the same time, you're actually trying to create an entirely new category of, lab insights or lab benefits management. What kind of reception did you get? Was it just the logic? Okay, I see the triangle, the diamond, PCR is ready, sequencing. I mean, what was the reaction?
So we spent a year talking to over 15 health plans about this possibility. So we had pieced together, Adam and I pieced together a team of about a dozen people. He was working on another company, and I pieced together the team for lab, and talked to a lot of health plans about what would be appealing to them, whether or not they had an appetite to be the first customer. Many health plans had an appetite to be the third or fourth customer, but not
Yeah.
the first. What we intended to do was to use a customer contract to pull down the capital from the private equity investors and then build the company around them. And we were very fortunate to meet towards the end of that year Blue Cross Blue Shield of South Carolina,
Mm-hmm.
which is a very interesting company in ways many people may not know. Not only have they been innovative on the health plan side, but they've actually built a technology company that's robust and serves nationally a number of clients. And we had a need for a technology platform as well as an innovative customer. And so David Pankow, their CEO, was willing to sign up for it. And that's really how we came to find a customer willing to be first. And we then spent a year building the company with them and around their health plan, and launched it sort of in late 2015 then. So that's the process. Find somebody willing to be first, who fits a profile for being a good partner, and then build the company around them. And then from there, we started growing with other plans. We intentionally went to regional Blue Cross plans first. They need to ultimately buy scale, quite honestly, and we were selling services in scale. And they also usually have a complex operating environment that if you can solve, other Blues will trust you. And then we slowly expanded out of there. So basically, find a first customer, build around them, and then we started selling into similar customers before we expanded our customer suite.
No, that sounds like a good path, and you need to find that customer who's actually doesn't want to be third or fourth, but wants to be first and has enough reasons to do that, and wants to be first for the right reasons and has that experience. So that sounds like a good path to go by. And unless you're in the field, you wouldn't know Blue Cross of South Carolina would be the place to look for that.
Yeah, I think a lot of people, I come from smaller states like Arkansas. Sometimes people don't realize the innovation that can be going on.
Yeah.
I'm very fortunate. I happen to live in Florida now. And when I was at Blues of Florida, we actually partnered with them and used them to serve some of our national accounts. So I knew about their culture, and I actually knew about their technology platform. And their team also stepped up with leadership, which is really the other ingredient. You need somebody on the health plan side willing to say, we will take this risk. And the leadership team there really did a great job.
So once you had that, the first customer and the capital, and then the second, and even the customer that wanted to be third or fourth, they, once they see what happens first, maybe they'll be willing to be second, and then you sort of figure it out from there. So thinking about where you are now, I was just seeing that Blue Cross, not of South Carolina, but of North Carolina, published a pretty impressive savings number of what they'd achieved with Avalon. I think over $100 million that they cited. Now, you mentioned having been in that seat of chief medical officer and all the different constituencies you're having to deal with. One thing I find actually is quite unusual is for a health plan to put a press release out there talking about, money saved and who they're working with. And there's something to the story there. And I wonder, what that partnership had been like and how you got to that point with them.
Yeah, it's a great question. So first customer is an interesting profile. And in this case, innovation was in their kind of culture. In Blues in North Carolina, affordability is really a culture. They really care about what the citizens of North Carolina have to pay for healthcare. And this has been through 3 CEOs since I've been working with them and several CMOs, but it's in their culture. And their CFO Mitch Perry's been there the entire time, and has some of their leadership team, Mark Warner, who's over network and cost containment. And that passion for affordability was really first what allowed them to be attracted to us, because our first product out of the gate was primarily focused on reducing waste in the system.
Yeah.
And so it saves health plans money. So they were prone to be interested in programs that save money, given that kind of cultural focus on keeping healthcare affordable. And so they were our second client. And at the time that we were launching with them, we were actually due to pull down another tranche of capital from Francisco Partners. And North Carolina was so intrigued by the value proposition, they asked if they, along with Blues of South Carolina, could actually fund a portion of that tranche. So they not only, if you will, kind of found the value prop for their own citizens and their own constituents, they really wanted to see it spread for others because of their focus on affordability. So that created a partnership mindset that I think allowed them to then bring to us over time new problems they might have identified and allowed us to expand the program. So when I think about it, with South Carolina, their culture of innovation allows us to get started, but North Carolina's culture of driving affordability and trying to layer in as much as possible drove that program to expand more broadly than it otherwise would have. So they've put us into areas of cost containment and outcome improvement that we might not have come up with on our own. So we work with them on helping manage the network that produces lab services. We help them manage everything around genetic testing, around routine testing. We've even started to connect some of the testing to the drugs that are paid for on the medical benefit side, so drugs you might get in your physician's office. They've really been an impressive partner on leveraging every asset they have, including us, to expand the impact we have on their membership. And that's really then, I think, part of how you end up with a press release is because it reflects well on them that they have helped us grow this program together, and really reflects their culture of let's keep healthcare affordable for the citizens of North Carolina. And Mitch Perry's even posted some really compelling articles on LinkedIn about other programs they're doing that is worth a look. So that's kind of how you get there. A partner who cares a lot and is willing to not only invest money, but invest time in growing the program.
Great. Thanks for that explanation. You talk about lab testing. Of course, there's all sorts of tests. You've got your kind of high volume, low cost, but they can add up, and there can be a lot of waste and a lot of decisions that are made by a cheap test either that wasn't ordered or one that was ordered and not in a timely way or whatever that have a lot of implications downstream. But then on the testing side, the genetic testing, which you mentioned also is an expensive area, less common, and I think also fewer guidelines and a lot of just not nearly as mature and also expensive. Now, I noticed that you recently have announced a big agreement for genetic testing utilization management with in partnership with Optum, which is a big one, and Palmetto. And I'm wondering if you could give a little background on that one. And, in particular, are there capabilities that, capabilities that you have from the base business, do they just translate into be able to deliver this sort of a solution at scale, or is there a new set of activities and capabilities that you have to put in place?
It's a great question, and I'm going to start with what we do to manage routine testing, because that is one of the capabilities that can now be leveraged into genetics. So there's several interesting challenges in lab. One of the base is the science of lab testing has exploded. I mentioned earlier, I think everybody knows genetic testing, but most people don't realize that even in routine chemistry or other things, there's an explosion of science. So, we can now take your cholesterol and break it down into 13 components. We can take vitamin D and break it down. We can put more antibodies on cell surfaces, all this stuff. So what happens when you have an explosion in science? And by the way, we saw this with new drugs in the 90s. What happens is it's difficult for the practicing physician to keep up with all that science. And the source of information they frequently receive is from the purveyors of the testing. And the natural consequence of that is to try to drive up too much testing, so have it used in situations where it may not be useful. So we built a program that first says we're going to help doctors understand the science of testing. So we have an independent clinical advisory board, and we codified in about 120 statements when lab testing makes sense. We then split those into routine testing and genetics. And on routine, we built a software package that can talk to health plans' operating systems and tell them when a claim comes through, does it actually conform to good science, or are there tests that are being run on this claim that don't? And one of the reasons we did that is many of the labs have programs. If you think back in the 90s when doctors used to order a 90-day supply of all medicines,
Right.
and many of those got wasted because we would stop it after 30 days and change. And the industry evolved to say, let's don't do 90-day supply. Well, there are similar things that happen in the way test menus are constructed by labs that will insert tests that are rarely useful and connect it to tests that are always useful. So our program really just helps separate those out and says you don't need to keep paying for those that are not useful. An example would be many thyroid panels that are constructed by labs include a test that is really appropriate for a pregnant woman who has a history of thyroid disease.
Yeah.
Well, that's a very rare situation, but that test is run in every thyroid panel.
So I don't need it.
Country.
You're saying
so that's an example of waste.
You're saying I don't need that one.
You don't need it.
Yeah. Thank goodness. Okay.
You don't need it, but you're going to get it next time you get a thyroid panel. I promise. So we built a software package that can really kind of machine read everything going on a current claim, a past claim in the provider file, and advise a health plan how to do that. The challenge and that's been our most effective product. That really is one we've now got, 15, 16 clients, 35 million lives covered on that. That's been the most, and there's nobody else out there with that type of program and that software package. Mm-hmm. So that has gotten us a lot of attention, including introduced us to Optum as well because of that unique capability. The challenge on genetics, as you've already alluded to, I think, is the science of genetic testing is just exploding. The coding and payment of genetic testing lags way behind. So what happens is you can't build automated algorithms with machine learning type support because you've got all these tests that are represented by a not otherwise classified code.
Right.
And you have to look at what's in the test. And the same games kind of go on. Labs themselves will take mutations that are useful to an oncologist in treating a certain kind of cancer, let's say non-small cell lung cancer, and they'll add in other mutations that maybe aren't as useful because they would like to build up a database of mutations. So our program works to say, hey, doctor, these 5 mutations make sense, but these 15 don't. Why don't we get the 5 and not the 15? But we do that in a manual process. While we have a system that collects data, ultimately we review it with nurses and doctors because of this issue of coding in many instances, not every instance. Well, so Palmetto GBA has a product called Moldex, which includes a proprietary coding system called Z-Codes, which one could easily think of as the NDC coding system for genetic testing. For your listeners who are in the healthcare space and know J-Codes on the medical side, they know J-Codes are, represent a whole bucket of drugs, and they know NDC is very specific. Well, this system they have is very specific to each lab or manufacturer and each test run. And Optum has licensed that and started building some programs around that. And our software package can take some of their programs and our science, I already mentioned our science, blend those together and start to automate now the way that genetic tests are covered by health plans. Whether they want to just make that decision up front or whether they want to make it on the back end, it can become more automated and more seamless. And so that's really, so we started with the root testing capability, and we're now leveraging the coding capabilities that Moldex represents and Optum's ability to use those and incorporate those and our ability to connect those to science. And we believe is going to be really a best-in-class program for genetic testing in the industry.
Great. It sounds awesome, and I'll avoid getting that strange thyroid test, I guess. But maybe from
Yes,
that's not even
exactly.
So now, if you go
to a plan we serve, you at least won't have to pay for it.
Okay, good.
Unfortunately, when that test comes through, about a third of costs today are paid for by members at the point of service. So one of the things that really motivates us is to help save them money out of pocket by not having their health plan pay claims that don't make sense for them.
So you talked about, this explosion on the genetic testing side, and you just all these not elsewhere classified codes and so on. Eventually, that will settle down, get codified, and there'll be some advances there. And so, if we look ahead, pick your time frame, 3, 5, 7, 10 years. How do you expect that those genetic testing benefits management will evolve? So, for example, will prior authorization be a factor in the future the way it is today?
It's a great question. Let me, if you don't mind, let me give a little more context before getting
Sure.
specifically to that. Some of it's around Avalon, some of it's around the industry. So we started with let's save money first. The easiest product to convince a health plan to buy is save money. But the real value of lab testing, as I said, is it's the diamond in the decision tree. And we've been investing now for the past couple of years in how to ensure that we address under-testing, which is a problem. So you have social determinants of health seem to be a factor in lab, just like they are in other parts of health. And certain conditions that have good tests may not be getting appropriately tested, and that results in the wrong care. So we've been focused on how do we now start to get the right test, and also how do we interpret. So many tests are more difficult to interpret than many of us think. We think, it prints out on that little piece of paper or in your EHR, and it says yes or no, you have it. And in particular, we think of mutations like that, right? We think genetic testing is this very binary, you have the mutation or you don't. Because maybe things like sickle cell sort of were our first exposure to that. But much of that is actually a complex statistical analysis of things that you see and trying to identify what that is. And so interpreting the results can also be tough. So we've been investing in our ability to do that. So where do I think we ultimately go? I think first is we need to right-size testing. There are people, for instance, there are women with breast cancer who, depending on the type of breast cancer, after lumpectomy would benefit from certain tests that would determine if associated chemotherapy would help them, adjuvant chemotherapy. We see a lot of women who would qualify for that who never get that test. And if you don't get that test, you're going to get the adjuvant chemotherapy. So there's a chance to increase that utilization and decrease the number of women getting chemotherapy after lumpectomy. We've already seen evidence that we can identify thousands of people with deteriorating kidney function well before the test result would be labeled as that, or well before a doctor would code that in a claim system, therefore identifying pop health earlier. So if you take this under testing and interpretation piece, that's job one, I believe. As we improve automation and decrease some of the friction in the system, it's possible and conceivable that we could perform all of the benefit coverage on the back end at the point of payment. I personally do not believe we will see that happen in genetic testing because I believe people will want to know, given the pricing and at times the cost structure, whether it's covered beforehand. So I think you will always see some level of upfront benefit determination, either because the patient wants it, the lab who's going to run the test wants it, or the doctor thinks it's appropriate. So I think you'll see that piece there, to go back to your question. But I think the real interesting challenge is less that and much more, how do we get the right test to people who aren't getting it? And how do we get the right interpretation? I already mentioned non-small cell lung cancer. There's a certain mutation that set of mutations that if you have it, dictates a new precision therapy. We see people who get the test run, we see them not have the mutation and still get the precision therapy. That's not helpful. So again, I think there's a lot of work to do on what we call lab insights. What test should I run and how do I interpret the result? That is the real meaningful impact to drive, and then try to reduce the friction as much as possible. But I think some level of benefit determination is always to be useful in high cost testing.
That's great. Well, Bill, it sounds like you have a lot that you've achieved, a lot on your plate just to do the scale up here of these new opportunities, and then there's probably more to come. So rest up and be able to handle that. Now, with that in mind, have you had a chance to do any reading for pleasure? And is there anything you would recommend, or anything you recommend we avoid?
So as you can imagine, I get to travel a lot in this business, so there's a lot of airplane time to read. I am a bibliophile who loves to have a real book in my hand, so I go ahead and carry them. You can imagine, given my industry, I recently finished Walter Isaacson's book on code
Sure.
breakers. Excellent book, I think. I like everything Walter Isaacson writes. I think I've written read every one of his from Einstein through Jobs to Da Vinci. But he's great. So in that book in particular, very interesting to me to see the science come forward. And also, I think for readers, very interesting to see then how it was applied in the pandemic.
Yeah.
I'm not sure it got as much press, and his book did a good job of bringing forward the role that what were competitive labs did in cooperating. So I like that one a lot. I had just read Eric Larson's Splendid in the Vial, which was his story of the first year of Churchill's prime ministership during World War II. Very fascinating book on how really close England came to falling,
Yeah.
and how much leadership matters. And I think in a time like we're dealing with a lot of volatility, very interesting to see that there have been even more difficult times around. But also, it's instructive how much leadership matters. So I've enjoyed that. And then I'll finish with this. I'm reading right now Alex Honnold, the gentleman who did the free solo of El Cap. I saw him speak, and he gave out his book, Alone on the Wall. And I just love reading books about excellence. And it's very interesting to read how much preparation goes in any of his climbs. Preparation, practice, and then also visualization.
Yeah.
Things we could all learn, I think, from reading that. So that's kind of been my most recent set of books that I've lugged around and enjoyed on some airplanes.
No, that sounds really good, Bill. Well, I'm glad that I asked that question, and I assume you only read the good books, so I won't ask for any recommendations of what to avoid. But especially the thing is, like, if you get it on the Kindle,
some of those I just
you just discard, right? I could probably find it in the back of me of the seat if I look for it hard enough.
Yeah. The ones I didn't like, I am not one of those who feels compelled to finish. I will abort and move on.
That sounds like good. Life is short enough. Well, Bill Kerr, co-founder and CEO of Avalon Healthcare Solutions, thank you so much for joining me today on the HealthBiz Podcast.
Thank you, David.
You've been listening to the HealthBiz Podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.